Welcome, everyone. Thank you for joining us tonight. So, we have our recording going, and I'm really excited for this one because we really rarely to do, physical therapy and getting into more of the biomechanics and stuff like that. So, we have Dr. Marcia Perretto with us today. And so, I'm going to kind of let you get a little bit started, talk a little bit about what you do and why you're interested in this disease space at all, how you got started, and where you want to go from here. So I'll let you kind of introduce yourself a little bit and start us going. And I have some questions, and we'll have questions as we go, but go right ahead.
Okay. All right. Hi. Hello, everyone. Welcome. Thank you for joining. Thank you for having me. It's always a pleasure to contribute with you guys and to be able to share the things that I have been learning because I believe that we are always learning better ways to provide care to patients like us, right? Because I'm also part of it. So my name is Marcia Perretto. I am a doctor of physical therapy. I have been in the field of medical field in general for 30 years. And I'm not that old. I just been doing this long enough. I start early. Um, and so I started my interest into all this kind of happened because of my own experience, right? For those that don't know, I have hypermobile syndrome. I have mast activation syndrome. I have postural orthostatic tachycardia syndrome. I also have cranio-cervical instability, multi-level segmental instability of my cervical spine. Um, and everything else that comes along with the comorbidities that come along. I have a bit of this, a bit of that. For those that don't know, I've been disabled back in 2010 to 12. I have gone through a lot in my life and end up in disability. And that's how my research started, trying to figure out my own diagnosis because I was told they didn't know what I had. Uh, Throughout the years, I not only stumbled initially on hypermobile syndrome, which was my diagnosis, but also started figuring out that there was more to it, like the autonomia POTS, CCI, Chiari, um, MCAS, Syringomyelia, all these things kind of just started appearing as comorbidities. And the more they appear, the more I study, the more patients I received, the more I had to study. So it just became for me a way of practicing in the medical field, a way to support and better provide care to my patients. So that's kind of how I end up and will continue studying this. So today, what I want to talk to you guys is really your roadmap to healing and understanding a safe recovery with EDS, CCI, Chiari, Syringomyelia, um, and all the relevance of this whole thing. All right. So let's start with let's start by saying that people living with Ehlers-Danlos syndrome or hypermobile syndrome, cranio-cervical instability or upper cervical instability, right? Because it's atlantoaxial and CCI, Chiari malformation, POTS and MCAS and Syringomyelia and a combination of all of this. These, you guys are the most informed and resilient patients I have ever met. Like, you live in bodies that behave differently structurally, neurologically, immunologically, and even metabolically. Like everything is different. So we don't fit that box that we medical providers learn in school, right? All those protocols, all those um, standardized types of treatments for us are like a bit different because our symptoms sometimes are just so mixed up and so complex, right? So because of that, you have also learned more medical science than most clinicians I have ever taught. So today, I just want to give you a clear evidence-based roadmap for healing that respects every system involved in your body, like And, the whole idea is really is like give you an idea of the collagen biology, the neurology, the autonomics, the mast cells, the energy metabolism, the if surgical, post-surgical adaptations. I want to try to cover as much as I can today. And this is not just about basic exercise advice, okay? This is about precision physiology. All right. So understanding why your body reacts the way it does and how we can work with those patterns to create stability and resilience, more so than give you this many repetitions or this type of exercise. Okay. So this type of approach is especially important for CCI, AEI, Chiari, Syringomyelia, and just because the upper cervical spine in general and the hindbrain region are uniquely sensitive to pressure, tension, inflammation, and all the autonomic fluctuations. So I want to see if I can cover as much as I can today. This is going to be recorded so you guys can go back, make notes. And I just want to say, we are very responsible on our Instagram page as well. And you can always go in there and ask questions. We either going to create a post to answer your question or we're going to answer your question directly. So let's look at the interconnected biology of EDS, CCI, or upper cervical pathologist Chiari. To understand healing, we first need to understand the layers contributing to the symptoms. Okay, so let's look at collagen structure first. In AGDS, collagen is less organized and less stiff. This really means that joints are unstable, ligaments will stretch easily, tissue fatigues quickly, and healing is much slower. This is why CCI, AEI, Chiari symptoms, etc., often appear or worsen the tissue, which means that the tissue um, meant to stabilize the skull and the spine cannot provide enough mechanical support, right? So things can get worse over time, and things can be worse from morning to afternoon or from one day to the other. And sometimes we don't understand, meaning we in our own bodies don't understand, well, I was doing just so fine yesterday. What's going on today, right? So the second thing we need to look at is the autonomic nervous system dysregulation, like a POTS, orthostatic intolerance, etc. The autonomic imbalance will lead to pulling, tachycardia, temperature swings, intracranial pressure fluctuations, and the reduced brainstem perfusion. Um, this directly worsens CCI or upper cervical symptoms and the Chiari pressure intolerance. And I also want to make a note here that not every patient presents with all the symptoms or the same combination of symptoms. So each one of us will have our own characteristics, our own cohort of symptoms, and different combinations in different times of the day, the year, under different types of stress and things like that. Okay. So now let's also look into mast cell activation syndrome, which we all know that they release mediators that increase inflammation, vascular permeability, ligament laxity, nerve irritation, and dysautonomia. MCAS can directly worsen cranio-cervical instability by softening the connective tissue and increasing neuroinflammation. So now we are starting to see that this is not only orthopedic anymore, right? This is not only a musculoskeletal thing. This is now involving other symptoms. Now we also have neuromuscular proprioceptive impairment in that. So the ligament laxity will force muscles to work over time, which will lead to muscle guarding, more sensory confusion, impaired joint position sense, and then the feeling that the head is too heavy to hold up. And then when we think it's okay, that's it, right? Oh no, there is mitochondrial stress too, right? So many patients have low ATP production, which is adenosine triphosphate, which is the energy of the mitochondria, right? And we're not going to go into this. This is very complex, but just think of that. That's the gas in your mitochondria, your energy production cell. Impaired oxygen extraction is a consequence as well of mitochondrial stress. So we don't get that oxygen circulating as much as we need. And we also have post-exertional malaise. So I want you guys to understand that this is not deconditioning. It's metabolic and it is autonomic. So you can't work out mitochondrial stress. You cannot recondition with traditional conditioning exercises. That has to be graded appropriately. And now we have to remember too that these five systems will interact. So when one destabilizes, the others may follow. So then the healing requires stabilizing all the systems, not just the bone or the muscles. So in conditions like CCI, AAI, Chiari, Syringomyelia, this interconnectedness means that the physiological instability can directly aggravate the brainstem compression, the neural irritation, and the CSF flow abnormalities. Okay, so let's look at the phases. So what I did is I start noticing that when I work with my patients, attacking directly strengthening, as it has been dictated always in rehabilitation, was not taking me anywhere, was not leading to a good outcome, was leading sometimes to crashes that we know well how severe they can be at times. So I looked into all these years of practice and I started noticing that we don't need a protocol because protocols require that you fit a certain behavior and that you actually going to respond in a certain predictable way. If there is one thing that we are, is unpredictable. So protocols might not work well. So strategies are better. Why strategies? Because with the strategies, we can have multiple strategies for the autonomic system, multiple strategies for MCAS patients, multiple strategies for mitochondrial stress, right? So, multiple strategies for sometimes the same thing. And then from those buckets of strategies, right? We have a patient with CCI, but then has multi-level instability of the cervical spine, and then has syringomyelia or has tether cord syndrome. We didn't even mention that yet, right? So now we have to look at it and say, okay, so this is a more severe autonomic dysfunction. We need to get the severe strategy in. We don't have MCAS on this patient, or we have a moderate level of MCAS. We pull that in. So kind of pulling the different levels of strategy to make a treatment plan for that one person. That leads to phases of treatment, right? So because you can just jump in and say, okay, we got it all, like, let's attack. That doesn't work again. So we need to create and divide this in phases. So what did I do? I created a multi-systemic phases of treatment. So let's look at phase one, physiologic stabilization. So that's your healing foundation. Healing begins with physiology, not with exercise. This initial phase one, is to calm the systems that amplify the symptoms. So if we are looking at a multisystemic problem, we need to address it multisystemically, right? So what are the key priorities here? Autonomic regulation. So we might attack that with specific breath work exercises, vagal tone regulation. Some patients respond better with some breath work just by itself. Some require tools for breath work. Some can do OMS and breath work regulating vagal tone. Others will need tools like vagus nerve um, vibration equipment, things like that. So there are different tools again for that. But essentially for autonomic regulation, we're going to be looking at breathwork regulation, vagal tone regulation, and through that regulating intracranial pressure swings. Okay. In the same phase, blood volume support, hydration, electrolytes, compression garments, positional strategies. Is this patient responding better in a flat position versus recumbent position versus sideline position? Where is that person better at? What is the position that they feel more comfortable, more supported, and safer? If you feel safe, you will be able to, if you feel safe, you will be able to relax into it and actually work and have a more predictable outcome, right? So the goal is really just to reduce orthostatic stress and brain stem strain. In that blood volume support, we might need to pull strategies along with cardiology and neurology specialized on autonomic disorders because we might need medication. There are phases for it. Doesn't mean you need medication for the rest of your life. Sometimes you do, but we need sometimes to pull assistance of the physicians, and we need to be able to communicate well with them as clinicians on my end to clinicians on their end. Then we have the mast cell stabilization. Uncontrolled mast cell activity increases laxity or tissue laxity and inflammation. Stabilizing MCAS improves tissue behavior and symptom tolerance. So again, do we need medication? Do we need an antihistamine versus a mast cell stabilizer? Again, we need participation of immunology in this process as well. Then bringing in gentle supported movement because reduces pulling, improves support circulation overall, right? Improves lymphatic drainage, prevents deconditioning, protects the cervical region, helps with muscle spasm, helps with muscle stiffness. That also has to be taken into consideration. Usually, this phase is often skipped because we clinicians are taught to jump into exercises. But without this phase, no strengthening program will succeed. I think the most important thing is that we must create a stable physiological baseline before asking your body to adapt to anything. Where most of these patients, most of us will be on a fight or flight or freeze because of everything we're going through. So if we don't stabilize the physiology of the body, we're not going to have good outcomes. For patients with upper cervical pathologies, Syringomyelia, tethered cord, stabilizing physiology reduces pressure fluctuations around the brainstem and the spinal cord, will ease symptoms like head pressure, dizziness, and even sensory disturbances. So that's a very important phase. Now, how long does that phase last? Very different. We have had patients that can be that master this phase because this is daily work, sometimes multiple times a day work because it's very dose, very homeopathic, let's say, right? So there are patients that are able to get themselves move forward in 2 to 3 weeks. There are patients that need 6 to 8 weeks. There is no timeline here. This is not a race, right? Now let's look at phase two, which is neuromotor reeducation. Each phase by itself, we can talk about each one for an hour, and this is not what I'm doing. So I'm giving you key components, okay? So phase two is a neuromotor reeducation, where we're going to rebuild control. So when the neck is unstable, we can begin by strengthening the neck itself. We start with the kinetic chain, which is the trunk, the pelvis, the shoulder girdle. Why? As anyone, for those that live in Florida, we're going to say the palm trees, but for those that live everywhere else, when you see a brand new tree planted, they do not put the support all the way to the top of the tree. They put the support, the planks around the mid to lower part. The goal is to improve the foundation of that tree. So that tree, that palm tree, will become stronger on the ground it's planted. So then that tree can be stable up above as it grows. Same concept, kind of. Okay. So we start through the kinetic chain because That's where you're gonna unload the cervical spine. These areas resorb or absorb the indirect forces. When they're stable, the cervical spine is no longer overloaded. All right. So this phase will really include the scapular activation, the deep core and pelvic control. There's a huge, huge, huge correlation of pelvic floor and upper cervical instability. Huge, okay? Or even not only upper cervical, but the cervical spine, the multi-segmentar hypermobility. So if you are going to work on your neck, not only that stabilization of the core, the scapula, the shoulders, etc., but pelvic floor is very important. All right. Looking into closed chain proprioception, for those that don't know, a closed chain, open chain. Open chain essentially is when your hands or legs are floating in the air up and down. Closed chain means when it's in contact with a firm surface. That gives us more proprioceptive input. Balance retraining, again, by balance retraining, I don't mean standing in one leg or trying to balance standing up. Sometimes balance retraining can be in a lying down position on a uneven or unlevel surface to start giving some feedback and input to the body. Visual and vestibular rehabilitation or stabilization. There is no gaze training, no eye training, no ear training. It's we rely on all that feedback in order to know where we are in the space. And then again, we're back to breath and movement coordination. Now that breath we learn on phase one, it starts coordinating with the movement. Okay. All this is actually just restoring the body's internal GPS. So when proprioception improves, pain decreases and instability sensations reduce dramatically. Now, obviously, there will be instabilities that are not going to improve. They're surgical. That is understandable. But going through a program that will give you a preparation before you even get to that surgery will give you a much better outcome surgically if that comes to a surgical procedure then. Um, I also want you guys to keep in mind that when there is an MCAS factor, there's neuroinflammation from the mast cells, um, or there's neuroinflammation, I'm sorry, that will worsen proprioception. Okay, so stabilizing MCAS improves this phase. So again, medication, removing things that can cause mast cell reactions, if we know what these are important too. So indirect strengthening is vital for upper cervical pathologies, and stabilizing the trunk and the shoulder girdle significantly reduce shearing forces at the upper cervical, including improving symptoms in Chiari Syringomyelia patients, which often experience the main thing that we hear here in the clinic will be reduced dizziness and improved balance as proprioception normalizes. Okay. So now we travel to phase three, which is a controlled collagen loading. This is really the heart of the EDS rehab. But that's where everyone kind of jumps the gun and starts doing. And that's where the problem is. Because this is where strengthening begins, but it's still not the way most people imagine it's going to be, right? Because fast movements will overload collagen too quickly, which will lead to collagen or to tissue micro tear. The tissue cannot absorb force at high velocity, not our tissue. Okay, we need to slow it down. We need to incorporate all the physiology you just heard me speak about. And then we are going to use eccentric, meaning what is eccentric and concentric? Just a quick refresher, and for those that don't know, concentric, the muscle gets shorter. Eccentric, the muscle contracts but it gets longer. We focus on the eccentric, where the muscle is getting longer, elongating in a controlled way. So we will work that concentric gentle contraction with the hold at certain different points of the range of motion, and then an eccentric phase of 4 to 5 seconds, depending on how wide the movement is. We will cut the lever, meaning levers, meaning how long that limb is in a space per se. This is a long lever. My entire arm is straight, but this can put a lot of shearing forces on my shoulder joint. So if I bend my elbow, I still can flex, extend my shoulder, and now my shoulder is not suffering because of the instability, is not suffering the gravity forces on my hand at the end of the range if it was a straight. So then we make shorter levers, okay? And then the controlled breathing along with that. So now we are combining concentric, eccentric contractions, isometric holds with breath, long and short levers, closed chain for the most part, and control breathing. This over time will teach the collagen to align, will stimulate safe collagen production, will improve stability because you're going to be recruiting the right muscles now. And remember, movement improves pain. So we are going to also start modulating pain through that stimulation. And the collagen will also start tolerating more load. Now, this can be very complex to explain. So just trust me on that. I will say that way because this by itself is a whole class when we are going through schooling. Okay. Now, if we have MCAS, we need to think again. So now you see how I have to keep pulling strategies for different things. We have mast cell activation syndrome. Slow loading reduces mast cell activation and improves tissue tolerance. Why? Because mast cell causes neuroinflammation. Neuroinflammation causes tissue weakening. Tissue weakening will cause tissue breakdown. So you see how we have to kind of rewind and even unintentionally, sometimes we can flare a patient. So, or you guys can flare yourselves and say, well, I did the same thing. I've been doing the same thing for a week. I was fine. And today I don't know why I have a flare after my exercise session. Well, what else happened around you that day? What type of stress did you recover? Is your heart rate variability too low? You should have backed off a little bit on intensity. You didn't realize. Sometimes we don't know how bad we are doing until we actually hit a wall, right? Now let's look again upper cervical pathologies. This slow precise strengthening will reduce micro movements at the cervical spine, and that can aggravate brainstem irritation. I can say that. Uh, because if you think about if you're moving too fast, things are not like I have seen plenty DMX images. I love DMX images because I'm looking at you moving your necks up and down and rotating, and I'm seeing the segments just not coupling correctly. And so I can see that if we actually would be using larger movements with that patient, I would be causing more tissue irritation instead less. So that's, for example, that's a good example of when we do slower, more precise strengthening movements, it will reduce these micro movements that I mentioned at the cervical, and that those micro movements can end up causing more tension and traction. And this, if we control that, it will limit symptoms of flares that are triggered by movement. So sometimes less is more, right? Now let's think about phase 4, which is the next level, right? Now we started strengthening in a gentle way. Now let's functionally integrate. And might as well, each phase could last months in some of us. And it's okay, right? It's not a competition. It's about getting quality of life and being able, each one of us has a different tolerance, a different combination of symptoms. So this is all about making progress in your own timeline. So now let's look at phase 4. Finally, let's say you graduate phase 3, you're doing great. Functional integration and mitochondrial pacing is going to be the next level. So this phase teaches your system to tolerate upright activity, daily tasks, and gentle endurance. So what has happened? We started you lying down on recumbent or sideline. Anyway, we went through every phase. Why? Because each position requires an adaptation. I'm a huge, huge fan of using the developmental phases like a baby goes, right? So think about a baby starts on their back, then they start rolling to the sides, then they go on their belly, then they're controlling their heads, then they're pushing themselves in like a little bit of a like puppy position, then they push themselves in all fours. So there is a whole developmental phase, a whole developmental sequence that I like to utilize because if we do that, the body recognizes it and say, "Oh, I'm familiar with that. I've done that before," right? So this phase now, on phase 4, it's putting you more upright now and putting you to daily tasks and putting you to more like consistent activities for gentle endurance. So now we start using core components like ground reaction force progressions. What is ground reaction force? Is the force that the ground, the wall, remember for each action, there is an equal opposite reaction. That's it. That's ground force reaction, is the ground reacting back into your body for the weight pressure that you're putting on it. That is not only ground, right? If you're pressing on your chair, if you're pressing hand against hand, there is a reaction. So we utilize that in the process of rehabilitation. We start working mitochondrial pacing. So now we start bringing you slowly to try to teach your body to readapt, to recharge itself, and assuming that we have looked at any mitochondrial genetic disorders, that's when genetics is important, right? You see how we have to use every specialty and how a rehabilitation professional should be aware of everything going on with the patient. Um, we need to look at the autonomic tolerance building and phases as well. So is that how is the what is the autonomic limitation of that person? And then we'll also look into movement efficiency training, right? What is that efficiency for that person versus someone else? We don't want to keep trying to make everyone to respond or adapt to the same protocol. Less wasted energy means fewer flares. So again, there's no rush here, all right? Now, if we got, let's say, MCAS, there we go again. Heat, friction, and intensity of the activities can trigger mast cells, and we need to be always aware. So the room temperature, any smells in the room, uh, maybe textures or materials that you're sensitive to, right? This all can be a stressor. This all can end up causing the or adding the MCAS overlay. So that needs to be taken into consideration again. When we get to that phase 4, we still talking to the different specialties, and are we like, okay, is do we still need this medication, doctor? She's getting better. She's not getting the dizziness anymore. Can we try to titrate down? We're communicating, right? You guys are talking, you guys are giving feedback. That's how we have to do this as a team. Now, functional integration is especially important for patients with upper cervical pathologies, Chiari, Syringomyelia, because efficient movement reduces the strain on the cervical spine and minimizes CSF flow sensitivity, pressure spikes, and the brainstem irritation during the upright activity. So see how it sounds simple though. It's not that simple. It's actually pretty complex because we are not easy. We are zebras of different stripes. And here at the clinic, we really need to stay on our toes day in, day out, each hour with different patients because it's different every time. Different every time for the same patient too. Okay. And finally, phase 5, life, reintegration, and resilience. Resilience is the big word here. Not only is mental resilience, but physical resilience, right? Tissue resilience, right? So this phase is about rebuilding your life, not just the body. So now we are looking at how can we work or adapt or modify whatever is necessary, ADLs, school or work tolerance, chores, travel. And by travel, I don't mean only getting an airplane, going somewhere, or getting in a car and driving for 4, 5, 6 hours. Travel from point A to point B. Some of us barely can make a 15 to 20 minutes because of the cranio-cervical instability or the cervical spine instability, right? My little story is when I used to go to Boston, our car was super, super soft. And in Boston, after the snow, when the ice melts, the roads are like, it's potholes. The potholes have potholes. That was my I swear that is true. Um, all that shaking on the car, a lot of times I was like this because I felt like I was a literally bubblehead. Ergonomics. Do you need a chair where your head is actually clearly supported so you can actually focus on what you need to focus without having to worry about your posture? Do you have enough back support? Are your elbows supported? Are your hands in the neutral position? Right? If you can't be dangling your legs, there are chairs where you can sit crisscross applesauce. Actually, I have one. I love it. Um, Compression, what needs to be done along with that ergonomics, pacing, super important. Let's pace activities. Let's learn how to utilize our energy more efficiently. And then long-term movement strategies. How are you going to keep that? How are you going to keep all that you have conquered? It's already hard enough because things can happen. Different things can come about as life goes on. So let's try to keep at bay at least what we have conquered so far. The goal here is not restriction, it's a strategy. So this is where really the confidence returns, right? We are like looking back, and this, for me, it took years. All right, I'm being very honest with all of you. For me, it took years. But I had to figure this whole thing out from the beginning. I didn't even know my diagnosis, right? When I was going through all this, hypermobile Ehlers-Danlos syndrome was considered so rare that the doctors would blow me off and say, nah, that doesn't, no, it's not it. You would look so debilitated. I'm like, more than this? I can't walk. I can't eat. Um, can't stand up. I'm like, how much more debilitated do you expect me to be? But anyway, so for patients with spine pathologies, right? This stage focus on preventing mechanical overload still, right? Because this mechanical overload can happen on daily activities. Then we're going to be teaching the body to maintain stability during real world demands, like walking, carrying things, or navigating environments. This is all part of being able to go back into the real world, let's call it. Now, let's talk about again that collaboration with other specialties, right? Why does it matter? Healing improves dramatically when surgeons, neurologists, immunologists, cardiologists, physical therapists, nurse practitioners, physician assistants, functional medicine, you name it, okay? If we communicate, because when we communicate, we can treat the system and not the one body part or not the one organ, right? Because you go to the gastroenterologist, he's treating your digestive system. But if there is no communication to what's going on with neurology and cardiology and autonomic nervous system, that digestion issue might not be a mechanical thing. It might be an autonomic thing. And there are strategies also in rehabilitation to help with that. So are we communicating, right? Now, let's say you had surgery, right? Surgeons correct the structure, but again, collaboration will assist in support the whole body system. Physical therapists, occupational therapists retrain movement, autonomics, and tissue behavior. So You regulate your physiology and your pacing. You're part of it. So you need to be an active part of it. Not only in a healthy way, questioning everything, right? But being active part of everything. So this is a teamwork. And that's the only way we can transform anatomy into function, pretty much, right? So again, coordinating care is essential because surgical stabilization alone cannot correct proprioceptive, autonomic, or inflammatory or motor control impairments. Those require specialized rehabilitation. So I guess I wanna close because I want to give you time, some time for you guys to ask a couple questions or for us to kind of chit chat a little bit, and I want to hear your experiences as well. But basically, the roadmap is stabilize physiology, autonomics, MCAS, circulation, etc. Restore neuromotor control with indirect cervical stability first. Low tissues, low limb precisely. Collagen adapts to tempo, not intensity. Build endurance with pacing. Protect your mitochondrial energy. And then reintegrate with strategy, not struggle. Your body is not failing you, okay? It is communicating with you, it's telling you something. We need to learn to sit back and listen as patients and as clinicians now. I'm speaking as a clinician. We need to learn to listen what you guys are saying because you're telling us what is wrong with you. Just not know sometimes the right words or the right order of symptoms or who is interfering on what. But if we sit down and we listen, we'll be able to figure a little more of what's happening to you. Okay. And when we follow the right sequence, healing becomes not only possible, but predictable, actually, right? So, and for us, all dealing with AAI, CCI, Chiari, Syringomyelia, all sorts of spine instabilities and tether cord, following a sequence that protects the brainstem, the spine, will reduce cord irritation, nerve irritation, and will build the stability required for like a meaningful long-term recovery. Okay. So yeah, I guess I covered everything I wanted to cover. I do know I have a couple questions here that were
Mhm.
asked ahead of time. Can I go over those?
I wanted to quickly ask a question that was relevant to the presentation though. So,
Okay.
um, I guess the question is, as the patient's going through these phases of treatment, how can they understand, like internally understanding their own body when they're building versus when they're struggling, like you say, with that they need to stop? Like, how can they tell that in themselves?
So there's different things. I've created so many tools here at the clinic to try to bring this to life, right? Because sometimes that's the hardest part. First, we do a ton of education. Our sessions are very educational as well because the magic, I always say, the magic does not happen when you guys are here at the clinic. The magic happens on the day to day when you're reproducing to the best of your ability what you have learned with us. So I have one thing, for example, that I have created is called the traffic light for um, the traffic light for EDS, the traffic light for autonomic system, the traffic light for fatigue. Uh, like you have, okay, if you have this symptoms or this presentation, you're in a green light. Today you can do everything you need to do. If you're feeling now this way and there is like a list of things, if you're presenting these symptoms, if these things are happening, now you're on a yellow light. These are the things you're gonna have to now to eliminate or to change to the approach. Now, if you're feeling this way, this is your red light. This is a recovery and rebuild type of day. This is not where you're going to be putting in your home exercise program full force with your cardio program. We educate that. That is like probably the most important question of the night, I think. It's really being able to understand that. We try to help as much as you can, but we really want you guys to bring it to us how you're feeling. So that's why we have actually a questionnaire post session where we say, how did you feel about the session yesterday? What has changed? What did not change? Because we ask you guys to keep notes of the day, the same day, the next day, the following day, so we can follow a graph. Did you have a drop in energy and you flare? Or you actually drop, but you recover next day and you are able to continue with the program. So that's how we are. In each time we hear from you guys, we learn more and we create more. So, but that's how we do it now.
So it's pretty much patient dependent is what I'm hearing. Yeah, got it.
Patient dependent. You can't, people are different. You can't
Hmm.
try to do it with a protocol, like I said. We have guidelines, we have strategies, but each person will fit at a different, if we like, we know when we have a pain scale,
Hmm.
like someone can be on the fatigue scale here or here, or on the response to treatment up here or down here. And that's what we are looking at.
Okay. Um, and then I wanted to start with the MCAS questions because we got one in the chat and I'm going to start with that one. Um, so in addition to like antihistamines, what are some general actions or even over the counter meds that patients can take while they're waiting to see a specialist? So, not necessarily medical advice, but how do you stave off that um, surge, I guess, in flare ups while they're waiting to see a specialist?
Well, that's a tough question for me to answer because, again, I cannot give a specific medical advice. Number one, I am a doctor of physical therapy. I'm not a physician, so but I can answer the question based on what I have seen the immunologists and the physicians in general to talk about. So it has been talked about significantly. It talked about a lot about the use of antihistamines over the counter, like um, Claritine, Zyrtec, things like that. Those are antihistamines. Remember, there are other mediators, all right? Pepsid is also another histamine blocker that is used. It's over the counter. I cannot tell you dosages and things like that because I will be giving you medical advice and medication advice, and I am not trained within the profession to be prescribing anything. Or I learned over the years, and I know this, but I can't really provide dosages like that. But I can tell you what is over the counter. There's quercetin as a supplement, really, really good mast cell stabilizer. You can buy at Amazon or pharmacy. Um, there is also turmeric with curcumin, excellent as well. There is nasochrome, which is a nasal spray that has chromoline in it. These are a couple things over the counter that can be that have easy access for you guys. But again, each of these things are very patient dependent, and most of these things will be histamine blockers. And like I said, there are other mediators. And sometimes what this person really might need is a mast cell stabilizer. And the only person capable of making that decision is a physician with extensive experience in dealing with patients like that. And remember, not everyone will have all the markers for mast cell when you go to the immunologist or to any physician. They say, well, I don't think you have all the markers, but if you're responding to the medication, this is what I learned with the immunologist I work with. If you are still given the medication, you respond to the medication, that is telling you a lot more than just a negative tryptase test on your blood work, for example.
Hmm. And then a follow up. This is one of the questions that we had gotten prior. So, what is your approach to treating MCAS as an underlying contributor to like cranio-cervical instability? And do you have any thoughts on they call it the Muldowney PT protocol, and I don't know anything about it, so I'm gonna let you answer.
So I think I spoke enough about MCAS, right? I explain how overloading the tissue can trigger inflammation. I also, so if you guys think, we discuss a lot of nutrition here at the clinic as well. Why? Not nutrition as a nutritionist would address with you, but nutrition in the sense of, okay, what are the things that can actually trigger tissue inflammation? Like eliminating foods that can be inflammatory will actually help modulate things like that. So also, uh, all the discussion that I have had, I tried to pull, and you guys saw that, I tried to pull all the MCAS and the POTS things in there because unfortunately that happens to us. But in clinic, from the control of our specialty here, to be very specific, is avoiding fast exercises, avoiding fast movements, avoiding crashes that can lead to tissue inflammation, that can lead to tissue breakdown, that can lead to mast cell degranulation, for example. That's a good, I think I spoke a lot about it, so I'm not going to repeat on that. But, and this is going to be recorded, you guys can go back and just get that. But I think if from the point of view of physical therapy, for example, it will be controlling movement, controlling the environment, the temperature of the environment, right? Bringing the patient to a calm state, because if you're on fight or flight, your body is firing every direction, everywhere. That is part of MCAS control as well, MCAS protocol. There's a lot to talk about. So, and in regards to the Muldowney protocol, so it is a very standardized framework. I think he was probably the one of the first groundbreakers when it came to that. It's a framework that's used by several clinicians. I don't treat from a fixed protocol. I use a patient specific clinical reasoning approach. So that's my difference to the Muldowney protocol. I prioritize nervous system and autonomic stability. I screen for neural flags, red flags, and uh, he is very structured. He's more protocol oriented for hypermobility. Um, I don't have anything bad to say. I think it's great, but not everyone responds to a protocol. Some people might do better with an individualized model that integrates other systems. So I think it is great for those that it works. Just like my system, it might not be great for some people, and his protocol might be the best one for that person. So we're all walking the same direction, right? We're all fighting to get you guys better. Doesn't matter which name we are using, which protocol, we just want to see you better.
Absolutely. Another question that came in ahead, how would you have a doctor write a script for PT if it comes to like muscles? So this patient has a muscle that's since their surgery, so I assume they've already had surgery. It's burning like a hot knife is being twisted. So nothing's really helping. It's been almost 2 years. So how does a patient like that, so far out of surgery, get a script for something like PT? And is there any
Physical
recommendation?
physical therapists are doctors. Doctors means that we actually, a lot of states, physical therapists are the professional of choice for musculoskeletal issues. So we don't necessarily need a doctor to tell us what's wrong, a physician to tell us what's wrong anymore. This is outdated. If the physician writes, evaluate and treat post-surgical of this, uh, hypermobile Ehlers-Danlos syndrome, POTS, whatever else is in that history. So just give us some red flags. Just say evaluate and treat. A physical therapist that is proficient within the specialties of hypermobile or Ehlers-Danlos, that understands CCI, that understand MCAS, POTS, will be able to do an evaluation that's appropriate for that patient. So if that therapist looks at that script and doesn't understand, you need a new therapist. And until you make sure that you found the right professional, because sometimes I'll be very honest with you, and I'm saying this not because I'm saying, but because I have heard from physicians that I work with. Sometimes they tell me, I don't know what to say. I don't know what to write. I hope you can identify the structure.
Yeah.
So that happens sometimes
Yeah.
because we're all working together trying to figure out what helps you.
Exactly. And then question in the chat. Have you worked pre or post neurosurgery for CCI if a patient's come to work with you from out of state? Is that something that's easy or difficult to do?
I have had a lot of patients that came from out of state. As a matter of fact, I work a lot with Dr. Fraser Henderson and some other surgeons I have from out of state as well. And we obviously need to see the distance. We need to see what that person needs. We need to see if that person needs to fly in for a period of time and then leave and continue with our supervision and collaboration with the local PT. We need to see what is the need. This falls under the consulting side of the clinic, but we always want someone, if possible, to be present for at least a couple days because then we get to see your body patterns. We get to see what happens when you move. So if that is possible, that is amazing. If that is not possible, we always figured out a way. I have
Awesome.
done that. In other words, I have done that in the past 13 years. I have done so many times.
Yeah. Thank you. I want to try to get to some of the questions that came in. This person has HEDS and TMJ, wondering about suggestions to get some relief. It's really just hurting them. Does the office have any specific treatments that help with something like that? And then as a follow-up, another question, are there any at-home routines that kind of reduce that tension without stressing that upper cervical spine, which I know is a big deal?
So the center of rotation of your TMJ is the vertebra number C2, cervical 2. Okay, so if there is a TMJ issue or TMD, temporomandibular dysfunction, and then there is a cranio-cervical dysfunction, doesn't at this point matter who came first, the chicken or the egg. It matters that we need to address both conjunctly. Okay. And then you're going to say, well, but you just said you're not going to treat the CCI, you're going to start indirectly. What happens to the TNJ? That then it's another strategy, right? So now I am bringing in, for those that want to look into, Mariano Rocabado is actually my mentor on that. I have been trained back 30 years ago almost by him on TMD or temporomandibular dysfunction. He is, if you can find someone in your area that's certified by him, you are in great hands. But he has, if you actually go, if you, because I can't give you direct what to do there, I have protocols for that. Okay, we have sequences, we have progressions on TMJ, but I need to know what's going on with the cervical. I need to go know what's going on. But there are really internal releases of specific exercises. But if you go on YouTube and you put Mariano Rocabado exercises, you're going to come across some basic things that he teaches or other therapists teach online. Those are like the entry foundational, some isometric and movement exercise they're taught by him as well.
Awesome. Um, I want to get to, we're going to probably go over a little bit. Is that okay with you?
That's okay. That's perfect.
Okay.
I was expecting that.
Okay, okay. I want to do this one next. What movements and therapies do you recommend for people who have like a symptomatic Chiari and EDS? So, can you, I know you talked a little bit about it, but the connection between the two, and what's helpful to maximize safety and mobility for that case?
Well, when you say symptomatic Chiari, what are really the symptoms, right, that we are talking about? Is that really a symptomatic Chiari by itself? Do we have a component craniocervical instability? You have hypermobile Ehlers-Danlos syndrome. I love the foundational work. I really do. I always start with breath work because breath work regulates intracranial pressure, decreases muscle spasm, decreases the tension around the face and the neck, right? Um, this is my foundational work. I really like that. Breath work with some gentle movements involving pelvic tilts involving some setting and engagement of the transverse abdominal muscle, and then breath work along with it, coordinating. That helps the symptomatic part of it. Um, Unloading, right? So if you're upright, the Chiari is going to be more symptomatic, recumbent with the head supported. We don't take the patient to unsupported head position, even on sitting upright until much later in the rehabilitation process, because even if you're sitting up, you need some sort of support. Sometimes we have a little bit of a recline, even if you are in an upright. So this way the head doesn't need to be fighting to be stay upright. So foundational work, again, is going to be the first thing. The breath work, you know what I love too for Chiari, I actually use a lot in the clinic is the ohms because it modulates vagus nerve. So
Hmm.
and make sure you vibrate the throat.
Wow.
Right? All those things, and then alternating with breath work. So close the door, kick the dog out, put a sign, nobody's home. Do not knock unless the house is on fire, and go on and do your thing, because you will see if you do 5-10 minutes of it, it's significantly improved.
Yeah.
And if
Kind of
it's not, there is something else.
yeah, that's fair. Um, a kind of follow up to that. This was asked in like the setting of a syrinx, so Syringomyelia.
Mhm.
So are you generally advising patients to be cautious or restricting their program, maybe in avoiding like Valsalva? I know some
We,
people talk about deadlifts. So what are your thoughts on that?
well, again, I have people that come in here extremely debilitated on a wheelchair, and I have people that get here. If we're going to talk about strength training with them, they're going to be teaching a class because they're pumped up going to the gym, right? But they're symptomatic. So sometimes you have to actually eliminate or like uh, bring back the intensity of the exercise, retrain position, retrain Valsalva, retrain modalities. What are they doing in the gym? It's talking about deadlift. Okay, what maybe that deadlift is not a good thing for that person. So yes, I look at what causes, what are the movements creating the symptoms, and I modify those. I don't start just taking things away. Obviously, Valsalva is not good for anyone. Let's face it, right? There's no point for Valsalva. I mean, actually, there is a point to Valsalva. We all know which one it is, but it's not going to be in exercise, right? Um, but I will look at what is happening, right? What is leading to the symptom. And then we work around that movement and recreate a different exercise that attacks or addresses the same muscle group, hopefully with the same result, but then that does not cause the symptoms.
Yeah. Another question, what are your thoughts on cranial sacral therapy being helpful with these types of disorders?
So it's an energy work, right? If it works for you, I mean, like some people say, acupuncture works for me, and the other one says, God, that didn't work for me. Meditation works for one, doesn't work for another. I think it's another modality. It puts you in a really good state. And if it can help you, if that energy work is helpful for you, do it. I think any modality that supports your well being should be used. We're not here to use one modality. We're not here to only do PT. We're not here to only do acupuncture. We need everything combined and in synchronicity. And as long as it's making you feel better when you're done, that's the key.
Yeah. I have a couple of questions about like things coming up with the holidays. Because
Mhm.
this is big stuff that kind of I'm actually really glad you're doing this because you can like describe different things that would help immediately. So, increasing travel and irregularity of the routine can make symptoms worse. So, do you recommend any way to help manage those car rides or flights or heavy bags? or even sleeping in an unfamiliar bed if you're in a hotel or at your
Oh, yeah.
parents' house or something. Like, do you have recommendations to like make travel a little bit easier on the holiday?
So, okay, let's start with packing, right? There are times we cannot avoid packing certain things. And sometimes it's for us, we end up having to pack more. Because I got to go the pillow, the brace, the compressions, I don't know, everything that we need to carry to feel better. So we have our first aid kit type of situation, right? Or toolbox. But can we use the luggage with wheels? Can we? I ask assistants. I mean, you look at me, you're going to say, what? I'm like, yeah, I'm not going to raise a luggage overhead. I have cranio-cervical instability. Why would I do that to myself? Right? So I ask for assistance. Because I have to pack sometimes, I have no choice. Like if you're going to go overseas, even you got to pack a lot. So try for packing the least possible, but don't leave essentials at home. If you're going to fly, like for me, flying, I require compression, but my compression cannot be tight on the waist because I'm sitting for too long. So what I did, I actually have compression, but I have cut the belt, the waist part a little bit because when I'm sitting, the waist expands. Sit there for too long, it starts cutting in your digestive system as well. It starts giving you a little discomfort. So do you need that? Are you going to wear your compression? Hydrate pre-trip. That's another one. Flying or driving, hydrate the day before a bit more and make sure you're hydrating throughout the trip as well. No alcohol when you're flying. Pressure in the airplane with, or for those that are coming from like mountains down or up to the mountains from from sea level, that also changes things, right? So hydrate, no alcohol. I know it's a boomer, but guess what? Alcohol is inflammatory too. So now you're flying, you have the increased pressure or the cabin pressure, you have the stress of the trip, and then you're already not eating that healthy initially because things will happen, and then you drink alcohol, then you set yourself for inflammation. So compression, hydration, your hydration pack if you need to do your electrolytes. Bring your pillow whenever possible. I actually have a carry-on that's especially that is specially bought for my pillow, and that pillow goes everywhere I go. Because if I don't have my pillow, I prefer to have an unknown mattress than an unknown pillow because I will wake up stiff and that is going to ruin my autonomic system next day. So I always carry my pillow. Eating, it's hard because now it's holidays, right? And everyone's cooking whatever they will cook for the holidays. And we want to be part of it and we want to eat it. But we need to be a little more strict with ourselves sometimes and say, you know what, I'm going to have a little piece of this, but I know that that ham is salty, but it's also cured, right? Or I know that sauce came from a can. So all these little details you need to be aware of. And bring your brace if you do have issues with your cervical. I actually use my soft collar as a pillow in the airplane or in the car as well. I
Mhm.
recline when I'm not driving. Interesting for those that do drive. If you're driving, your arms are supporting you and your head is against the back seat, you're more supported. Now, if you are a passenger, you're a little more loose in the car. I feel more my instability when I'm a passenger than when I'm the driver. So I always carry my soft collar and I recline my seat a little more to have the head more supported off the gravity line.
And then holiday activities. So maybe you're
Oh.
cooking or baking, family games. Do you recommend how can those be adapted to um, keep someone active without destabilizing anything? And then B, do you recommend frequent rest intervals, or does
Mhm.
stopping and starting aggravate symptoms?
Pacing. Pace before you aggravate anything. So know that you're going to participate. Some people say, come on, nobody else needs to do that. Why do I have to do that? Well, you have the choice of not doing, but then you're going to flare and you're going to miss the other days. So I would say, let's say you're playing board games, right? There's a lot of leaning forward and a lot of gravity pushing against the skull. For those that have more instability in flexion, that might not be the best thing. Well, can you get yourself closer to the table? Can you sit a little more upright? Maybe you need the brace as you're doing such. Um, can you maybe play the game for about 25, 35 minutes, 40 minutes? What is your tolerance level? When you starting to feel like, this is starting to become uncomfortable. Hey guys, I'll be right back. Someone else take my place, or I'm sitting out on this round. Go take a break. Lay your head back. The game is going to be there when you come back. Nobody is going to be upset at you. Sometimes we are more concerned than other people will be. And uh, by cooking, can you sit down? Can you adapt to that? Can you go to the table, to the dining table and chop that ingredient versus standing on the kitchen and in the kitchen and doing that? Now you're going to say, well, but I need to cook. I need to get the turkey in and out of the oven. Well, if you're cooking a turkey, there's more people in the house. So someone has to do the job of getting that turkey in and out so you can baste it, right? Someone else can get that assignment. Don't be afraid to delegate that task, right? Someone else can set the table. Someone else can baste the turkey. Someone else can toss the salad. Uh, Delegate, participate, but also delegate. I think it's fun when everyone does it all together.
Yeah, it makes it more social, I think, too.
Exactly.
Yeah. And then specifically, say you're having a high symptom day. Um, how do you
Mhm.
typically decide when it's appropriate to do something like putting on a collar or, taking more rest than usual?
So, what I do, I follow my heart rate variability. This is something I have been developing now. It's something I'm going to launch for next year for the patients, is the heart rate variability tracker. There are trackers out there, but how we track for our program is what I am doing. So start tracking your heart rate variability. There are different uh, um, tools and gadgets you can use, right? The most common one is called Visible. You can track with the bracelet, or you can track with putting it as an armband. My opinion, the closer to the heart, the better, because we have a tendency to not have good circulation towards the extremities. So I tested the Visible. I saw that for me, it worked better up above on my upper arm. My favorite, my heart rate variability with a chest strap. All right. So the Polar Age 10 is a great chest strap. It's a little more on the expensive side, but it's if you get the Polar Age 10, and I will tell you guys the app right now because I use it. It's called, let me make sure that this is the right one. It's called Cubios. K Kubios HRV. Cubios HRV. You connect the Cubius to the H10 band, the strap, and it gives you your readiness. I don't know if you guys can see it. It gives you your readiness. You will know where you are that day. So you can see that I was really good 2 days ago, and I have been stressing out over a couple things. So guess what happened today when I saw this? My strength training became a walk. I had a strength training session I was going to do today, and I realized that I couldn't, because if I did tomorrow, I would be down on the 40s. So I learned where my redness is best. And this is very personal. So if you guys start tracking your symptoms along with the redness with this app and the heart rate variable, the chest strap, you're gonna realize where you are at. And then if you're having a bad day, uh, you know, knowing that you have to peel back on the activities, even if you're like, well, but I was supposed to cook today. Well, guess what? Someone else is doing that for you. You're going to just be the boss. You're going to say, get the salad, get the chicken, get the this, and you're not going to be able to do as much. Or you're going to do, but you're going to take breaks. You do for 15, 20 minutes, and then you take a break. And that's the day you add more. hydration if it's a more autonomic. You add your compression. You might have to take your antihistamines or mast cell stabilizers or an extra dose of them if you're already regularly on them. All these things have to count.
Hmm. And then we're really late, so I just want to ask one more question that came in the chat, because I think it's a good thing for people to end on anyway.
Yeah.
Um, how do you recommend that patients advocate for themselves if they know that like exercise will trigger them and flare them up, especially if certain things are being said in clinicians' appointments that it's not really relevant to their specific situation, especially um, like maybe some outdated information. Um, how do you advocate for yourself while maintaining, that relationship and being respectful with the provider? How do you approach it, I guess?
Communication is the key, right? So if a clinician will be upset because you brought in data that is new, then you might need to reconsider your clinician. Because a good clinician needs to be able to say, I don't know, but I will look into it. Needs to be able to say, oh, thank you very much for making me aware of this. I'm going to read this and I'm going to get back to you. This is what a good clinician is. So if you're getting in, not every, when we talk about exercising tolerance, what type of exercise are we really talking about? Because gentle movement is exercise. It might not flare you, but maybe someone is getting through a much stronger back to back to back movement. And that is then an exercise intolerance. Is it an autonomic intolerance to the exercise and not really the musculoskeletal or orthopedic intolerance? Is this a mast cell intolerance? So but you have to bring up and say, hey, that's why we send out those forms that I said the next day after our visits, because we want to hear, how did you feel after the session? How did you wake up this morning? Did you have a mast cell flare? Did you have achiness throughout the body? Did you have a bad night of sleep? And that's where I'm going to incorporate heart rate variability now, because we'll be able to see, okay, if you did therapy today and you took, a drop on your heart rate variability next day, that means we need to back off. Heart rate variability is a huge predictor of recovery overnight. So if you can keep track of that and then you can keep track of your symptoms, you can bring to your therapist and say, hey, I noticed this. And I know you might not be familiar, or maybe you have not noticed this on me. But let's communicate better, because I like what we are doing, but I want to step up to the next level on this. I want to really be able to get better and I want to work with you. Because keep jumping from professional to professional to professional, it's always getting you to the beginning. You never move forward because you keep going back to the beginning. So obviously only change the professional when you see that there is no interest in helping you or no interest in learning. But don't change the professional all the time, because communication might improve that relationship and might improve your outcome.
Yeah, absolutely. Um, we might have to do another one of these because there's still questions that we didn't get to, but I
Yeah, we
do
can
want
do we
to,
can do a Q&A one day. How about the
yeah,
Q&A one only? That'll be
yeah, that's
fun.
perfect. But how can people get in touch with you if they wanted to come see you? And I wanted to just thank you for doing this with us, but how can people get in touch?
So you guys can find me on Instagram, and my handle is at the underscore EDS underscore PT. So at THE underscore EDS underscore PT. Tons of education in there. You guys can also get in touch with us at the clinic. The phone number at the clinic is 561-366-2435. You can text the clinic, call the clinic. Our email is info, at Actify, ACTI, I can't spell today anymore. Actify, ACTIFYPT.com. So info at actifypt.com. There is a Facebook page as well. Same thing, Actify PT. And yeah, through you guys at Bobby Jones as well. If you forgot anything, don't know how to find me, that's another way to find me. And the website www.actifypt.com. Our blogs are also pretty informational. So yeah, that's how you find me.
Awesome. Thank you so much, Dr. Perretto.
Of course.
Thanks everyone for joining us tonight. This has
Thank
been
you.
great, so I do think we should
That
do another one.
Listen, guys, thank you. So definitely, I would love to do it as a Q&A even. It will be a nice back and forth. Thank you guys at Bob Jones Foundation. I really appreciate the work you guys have done all these years for everyone. And I appreciate you for who you guys are. You are amazing people. You have a big heart. And I really appreciate being part of this and being included and invited to be here with you today. And to all of you that attended, I really, really thank you guys for being here tonight. And for those that are going to watch the recorded, thank you again in advance for watching. And I hope this was, even if a little bit, helpful to each one of you. All right. All
Awesome.
right.
Thank you.
Thank you
Thanks, everyone.
all.
Thank you. Good
Bye.
night.
Good
Good
night.
night.